Now, I would like to call upon Dr. SWARAJ BHATTACHARJEE. He'll be speaking on dealing with reverse pupillary block. So he is heading the Lakshmi Eye Hospital in Tinsukia, Assam. He is also a prolific anti-segment surgeon. Over to you, SWARAJ.
Good morning, everybody, and thank you, Dr. Jayasree, to include me in your instruction course. And greetings from Assam. My topic is dealing with the reverse pupillary block. No financial interest, of course. Normally, the pressure in the posterior chamber exceeds that in the anterior chamber due to the physiological degree of resistance at the pupil. Since the iris rests posteriorly on the anterior lens capsule, so there is a normal flow of fluid from the posterior chamber to anterior chamber. Before speaking out about the reverse pupillary block, we must know what is relative pupillary block. There is anterior iris bowing where the pressure simultaneously dilatation of the pupil renders the peripheral iris more flexed. This pupil block causes the pressure in the posterior chamber to increase and the peripheral iris bows anteriorly. Eventually, the iris touches the posterior corneal surface, obstructing the angle and the IOP rays. And just contrary to it, we had reverse pupillary block, where in some situation there is floppy iris and the floppy zonules. Now, pushing the BSS with the cannula, the pupillary edge compresses against the lens. There develops a compartmental syndrome. The anterior chamber pressure increases, which makes the lens to be pushed posteriorly. In some situation where the reverse pupillary block may occur during cataract surgery, which includes high myope, post-vitrectomized eyes, and the young patients who are undergoing surgery. Pseudophakic reverse pupillary block may occur in patients even with the pupillary optic capture in the sulcus fixated eye well. The clinical scenario in the reverse pupillary block: first, there is posterior displacement of the lens iris diaphragm, marked deepening of the anterior chamber, posterior iris bowing, pupil dilatation, and ultimately leading to the significant patient discomfort. The reverse pupillary block causes the lens iris diaphragm syndrome, which begins when 360 degree of the iridocapsular contact occurs, which is called as lens iris diaphragm retropulsion syndrome, or LIDRS. Now, this reverse pupillary block are seen while doing the hydrodissection during introduction of the irrigation port. And remember, it happens every time when we enter. And more with the use of the dispersive viscoelastic like Hilon 5, Viscoat, etc. Now, the management of the reverse pupillary block, how to prevent it? Preoperatively, proper history taking. We should look for the myopic patients. Are there? Meticulous biometry to use the new generation formula, proper fixation to get the accurate axial length. Intraoperative, we should have a low IOP phaco, low bottle height, and low irrigation setting. Now, what to be done in the actual scenario? Separating the iris from the anterior capsule rim with the IA tip, the phaco tip, or any available instrument, which equalizes the pressure between the anterior chamber and the posterior chamber, results into the iris will immediately return to the more physiological position. As the iris root and the zonules are attached to the ciliary body, lens will also return to its normal position, and ultimately the chamber reassume a normal depth. Any degree of discomfort the patient was experiencing from the syndrome will dissipate once this situation happens. This has some cons also. The pupil will decrease in the size. If the ciliary body has been stretched for a period of time, the pupil may begin to become more myotic due to the release of prostaglandin upon stimulation of the ciliary body. A word of caution in the myopic eyes, which carries a higher risk due to the larger anterior chamber volume, which affects the phacodynamics. Posterior chamber volume is also increased, creating greater aqueous humor flow into the anterior chamber. The risk of the tear in the posterior capsule increased, and there is a more risk factor for zonular weakness. Ultimately, all this situation leads to the more and more reverse pupillary block. I like to discuss about a case which was a 54 years male high myope with the axial length to the extent of 27.13 millimeter, NSC grade 2. IOL power came out to be +4 with the target refraction 0. While doing the optical biometry with the IOL Master 700, here we could see the axial length very nicely, 27.13. It was NS2, so it was very comfortably coming. But the difference in the steep meridian and the other meridian, it was minus 2.894 degree. In the other eye also it is same. Now we go for the online hour power calculation with the Barrett Universal 2, and we got a 4 diopter meniscus lens to be the correct power. We are using Alcon Expand series lens in this case. I like to share a small video. The post-operative outcome, we have seen that it has got a very high cylinder. So ultimately, patient got a 6/6 partial vision with 0.50 spherical with -2 diopter, 90 degree. The residual toric component has been covered with the glasses. There was no way out to add a toric lens in this situation. So what are the take-home points? Normally, the zonules and the ciliary body are strong enough to resist excessive posture displacement. Still, in some situation, reverse pupillary block occurs. Adequate pre and para-operative measures helps to manage the situation comfortably. Armamentarium must have a backup IOL CTR if the situation demands. Thank you so much for a patient hearing.
Thank you, Dr. Swaraj. Indeed, that was a wonderful video, and I think I can see a few young ophthalmologists out here, so they might have learned a lot from